My name is Andrea Owens. I am a vascular access clinician. I am a nurse, and this is my story. I attended my first AVA conference in 2010 here in National Harbor. I would tell you that I most specifically remember one breakfast symposium that I attended where I listened to Sorrel King speak about her daughter Josie. That impacted me and my practice because as a former critical care nurse and an infusion specialist for many years and a clinical educator, once again I was reminded that we are the patient's advocate, and what we do and the choices that we make each and every day make a difference. They make a difference in the lives of our patients, in their families, and our colleagues. So it is so very important that we remember who we are, why we are here, and what our responsibilities are. So I have a specific story about a patient that has happened a few years ago, but has always been very important to me because it was one of these stories that I would use to explain to my clinicians why it is so important to be an advocate for the patient. And sometimes you risk your job. You may risk relationships with other individuals, but our responsibility is to the patient. And I would tell you that this involved a young woman, relatively young, who had a revision of a previous surgery, and she was in a lot of pain. She was going to be on extended antibiotic therapy for many weeks, and so a PICC line was ordered. It was expertly placed by the clinician, and the clinician had evidence of the length of the catheter. It had been trimmed. When the bedside chest x-ray was done and she went down to view the x-ray, was unable to really see the tip of the catheter in the lower third of the superior vena cava. The radiology report came back that the catheter was short, and she was not in agreement with it and said, I want to know where the rest of my catheter is. She had evidence of where she had trimmed the catheter and how long it was. So she called me. I arrived at the facility and I released her. And from when that catheter was replaced, or when that catheter was replaced, to when it was finally determined where the tip terminated was more than 6 hours. What happened in between there is the story, because I requested another chest x-ray. It was done. The patient was in considerable pain. She was very, very emotional about what was going on. And so to be her advocate, because the physician wanted us to replace the catheter, which we did not want to do, it required multiple chest x-rays, inconvenience to the patient. They would not let me speak to the radiologist who was off-site. So I had to talk to them via the staff, and I had to stand up and say, I need you to tell me where the rest of my catheter is in this patient. Eventually I was able to speak to the surgeon who listened to my evidence, my discussion, why I didn't want to do it, using evidence-based support, and said, please allow me to use a contrast to check to see if this catheter is in the place where it needs to be. He allowed that. We did instill the contrast, and sure enough, the tip of the catheter was at the caval-atrial junction. In that time, I made some people angry, and I stood firmly and said, I will not remove this catheter until you can tell me where the rest of my catheter is. And this is not to be against the physicians or any of the other healthcare professionals that were working with me. We were all trying to come to the same goal, and that was to give this patient a viable line that would help her beat this infection and come to the end of the therapy and be healthy. So in the process of this, it was important to understand that I needed to stand. And I needed to stand firmly, and I needed to argue my position from a position of strength and information. So in telling this story, I would explain to you that the evidence and the information that we receive from AVA and our colleagues and the research that is done supports us in our practice, supports us in standing in the gap for the patient. The foundation and the research that is being done to help us have this evidence is critical to us in our practice each and every day. So I would offer to you that we need to remember why we are there, who we are there for, and our story should be that we are there for the patient.